Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode features three experts in the field, Dr. Cristina Mussini from the University of Modena in Italy, Dr. Martin Witzenrath from the University of Berlin in Germany, and Dr. Michele Bartoletti from the IRCCS Humanitas Research Hospital in Italy. Listen in as these experts discuss strategies for treating patients who are immunocompromised with severe COVID-19 in the hospital setting, including effective use of antiviral therapy, dexamethasone, and other immunomodulators like JAK inhibitors or IL-6 inhibitors. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on our faculty, along with a link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started and hear what they have to say about this important topic, starting with Dr. Bartoletti.
We already talked about antiviral treatment when we talk about guidelines, of course, but we're going to try to focus more on antiviral treatment to see what are the results of main clinical studies. So the first study I would like to show you is Solidarity's trial. Solidarity was a large trial, that assessed a large number of drugs. It was very important because it helped us to differentiate which type of drugs are very useful, which one should be avoided. For example, I remember that Solidarity assessed hydroxychloroquine, azithromycin, interferon that are not used anymore. And also, it assessed the use of remdesivir versus control for hospitalized patients with COVID-19. And the first part of the trial, it was very surprising, in my opinion, that the trial did not show any benefit in terms of outcome of patients treated with remdesivir and versus control. However, after they complete the whole study and they do also meta-analysis with the other of the trial, this trial was able to show an important benefit of remdesivir versus control. I think that the results should be commented because if I remember, in my center, for example, we participated in the Solidarity trial, and I remember that patients that were enrolled were patients that it's true that they were hospitalized recently, but in that way, in that part, on that wave, and that in our organization of healthcare, I remember that patients that we hospitalized were very advanced because they stayed at home for a long time with no treatment, and only when they became very, very critical, I would say, they get to the hospital. So we have to remember that these patients were enrolled in the first trial, first randomized control trial using antivirals. And we know, because Martin already showed, that antivirals are very effective in the very beginning of the disease, because in the very beginning, we have a higher viral replication. So, however, when the whole database was assessed with more 88,000 patients, this trial demonstrated a benefit in the use of remdesivir versus control in hospitalized patients with COVID-19. Beyond a randomized control trial, the Solidarity is not the only one. We have a lot of other trials. There's a lot of real-world evidence data. This is a retrospective study using the PINK-A database, which is a large database in the US. And this study enrolled nearly 30,000 patients, so it's very huge in terms of amount of data. And this study was also focused on the immunocompromised patient. What we see is that across the variants, the multiple waves of variants in the US, the remdesivir use was associated with the lower 40-day and 28-day mortality compared to controls that are patients that were not treated with remdesivir. Beyond remdesivir, we all are other antivirals. We should talk also about dexamethasone or immunomodulating drugs. So I think that we know that dexamethasones should be used in patients who requiring oxygen. But we know that when this drug was used in the very beginning, a lot of patients, even with no oxygen, were treated with the dexamethasone because most clinicians wanted to treat the patient very much. We know that according to the trial that demonstrate the benefit of dexamethasone, patients not receiving supplemental oxygen had higher mortality when were treated with dexamethasone. And this is paradoxically that patients that require low or high flow oxygen were receive a benefit in terms of outcome when they were treated with dexamethasone. This is another study showing that the patient that received dexamethasone, even with no need for supplemental oxygens, but they were also treated with antivirals, receive a very important benefit from antivirals, reducing the mortality compared to controls that were treated with dexamethasone alone. So the message that we would like to give is that if you wanted to use dexamethasone, even though this is not recommended by guidelines, please remember to use also an antiviral because this could decrease a lot of the mortality for COVID-19. EpiCovidAir, which is a large database of patients with COVID-19 and hematological malignancy that enrolled nearly more than 1,000 patients with these conditions. And they do an analysis about the use of dexamethasone in these patients. And this is very interesting. This analysis was about 500 patients receiving dexamethasone and 470 patients receiving dexamethasone plus antivirals. With these patients were hematological patients with a different type of conditions. When the patient receiving dexamethasone alone, there was a mortality that was higher when compared to dexamethasone plus antivirals. These results are also shown better in Kaplan-Meier curve. When they stratify to patients that were at home, hospitalized but not in the ICU, or even hospitalized in the ICU, they found a benefit among patients that were receiving dexamethasone plus antivirals when compared to antivirals alone or dexamethasone alone. So remember that if you wanted to use immunomodulants, especially in the immunocompromised patients, remember to use also an antiviral because this is very important for this kind of group of patients. We know that immunocompromised patients has already a condition that it theoretically should lower the inflammatory response to viral, bacterial, or fungal infection. So what do you think about the use of dexamethasone in this group of patients? Should be avoided, or we can use it but with concomitant antiviral, or there is a space on this type of drugs alone without antivirals? What's your opinion?
I would not state that we have to avoid dexamethasone in every patient that is immunocompromised. Obviously, there are situations in which these patients may benefit from dexamethasone, for example. Nevertheless, the data are very scarce on this. And of course, we have to use it with a lot of caution. And this is what you very nicely just demonstrated on the basis of clear data, that we should be very careful with dexamethasone in severely immunocompromised patients, and only very small portion of these patients may benefit from dexamethasone. And particularly in COVID-19, these patients then obviously need an antiviral therapy alongside or even without dexamethasone.
Cristina?
I think that in this patient, it's very difficult to use only dexamethasone without the antiviral. Because as we think about the different phases, we know that the viral phase lasts much more than in immunocompetent. So usually we use, even in more advanced patients, we use antiviral. So I don't think that there is the need to use dexamethasone without antiviral. So we first start with antiviral, and if it doesn't work, we add dexamethasone. So I'm very cautious about dexamethasone because I've been burned, as all of us, at the beginning where they said that during MERS, dexamethasone was counterproductive. And so we didn't use it. And then the recovery trial showed that it was beneficial. So I would not say that from one study there is some law, carving the stone. I think that it's good to use, it's a weapon that we have. I don't think that it's really something that, as you said, should be avoided.
We should a bit more elaborate on that and differentiate between, mildly or moderately immunocompromised patients and then those with really severe immunocompromise. situation, because even if you have not so many, but still some neutrophils and T cells and so on, they can get mad and really produce a hyperinflammatory situation in which you would like to give dexamethasone, or an immune response that does not resolve over time, for example, because there is also still virus there. And in this situation, it might sometimes be beneficial, but again, with a lot of caution.
As we know also that steroids can represent a risk factors for fungal infection in this patient. So it's a clinical picture that it's very complicated. But I would not say yes, or I would not say no. I would say that probably in this patient, we use everything that we have if the clinical picture is getting worse rapidly. So I would not say that someone would, say, no, never dexamethasone.
Yeah, it's true. And I think that as Martin says, is very important. I think that in the group of immunocompromised patients is very heterogeneous. So we generally consider immunocompromised patient neutropenic cancer, hematological patients or transplant patients, or even patient with the cancer receiving chemotherapy. I think that these two groups are very different from each other, and probably dexamethasones in the cancer patients could be still beneficial, but I don't think that in hematological patients with a completely neutropenic patient is still important. So I think that we have to differentiate a lot between the whole group of immunocompromised patients. And I think that probably in this group, especially very, very immunosuppressed, the dual antiviral therapy or combination antiviral therapy could be a good weapon when they don't respond, or even when they start with the critical condition. Because there are a lot of case series and case reports showing that there is a lot of beneficial. And I think also from my clinical perspective and experience, they respond very well when we start dual antiviral treatment. What do you think about this? And do you have experience on that in your setting, in your hospital?
Yeah, I mean, it was what I was saying when I said we use everything that we have. I mean, I think that we use also dual antiviral therapy in order to get rid of a positive swab, and maybe because they have to undergo chemotherapy, for example, but also in those where their immune system is really zero, and you need any weapon in order to, defeat the virus. And you know that they don't have lymphocytes, that they don't have neutrophils, that they don't have cells. So it's better to use all the antivirals that we have. So dual antiviral is absolutely something that we have used in a few fortunately in a few patients. It's not something that we have to do it in everybody. So we already mentioned many times the immune modulators, and among the other immune modulators, we have two groups. One is the JAK inhibitors, and we are talking about baricitinib and tofacitinib, and IL-6 inhibitors, tocilizumab and sarilumab. So baricitinib. Why baricitinib? Baricitinib because it's easy to take. It's oral. It's not very expensive. So I think that it has several opportunities to be used, and its use and its recommendation is based on some phase 3 studies. So the 3 studies were cough barrier 2, and recovery. The population, they were all hospitalized. In the cough barrier, we are talking about more than 1,500 patients, 79% on steroids. The rate of progression to respiratory failure and to death did not differ between baricitinib and placebo, even if there was a trend, because it was lower in baricitinib, it was 28% versus 31% in placebo, but it was not statistically significant. What differed? It was the 20-day all-cause mortality. So I think that this is a very good result. Another double-blind placebo control was the COVID-2 that was in much less patients, but they were in invasive mechanical ventilation or in ECMO. And again, 20-day all-cause mortality was lower with baricitinib, 39% versus placebo, 58%. And the risk reduction was 46%. The recovery, it was an open label because it's the adaptive platform from UK. And it was baricitinib plus standard of care versus standard of care, more than 8,000 patients. The 20-day all-cause mortality was lower with baricitinib because it was 12% versus placebo, 14%. And there was a 13% mortality reduction with baricitinib. The other drug that is tofacitinib for severe COVID-19. It was studied in Brazil and it's very expensive. That's why we don't use it routinely, at least in Italy. We never used it. And what we can see is that in Brazil, in this multi-center, double-blind, placebo-controlled trial, almost everybody received glucocorticoids, almost 90%. But the severity of the disease was very heterogeneous because 25% were not receiving oxygen, 63% were on a low flow oxygen, while 13% on flow oxygen. The risk reduction of having death and risk of death and respiratory failure at day 28 was 37% reduction in those using tofacitinib. Compared to placebo. I think that it's important to really select well the population and probably at the end of all of these studies, we don't have a single study that could have where we could see the real benefit of any of these anti-inflammatory drugs because the results are very heterogeneous. There was also a meta-analysis. All these meta-analysis, all these comparison among trials really are led by some of them. We have seen all the meta-analysis on tocilizumab before the recovery trial that showed that there was not a big benefit. After the recovery trial, there was a benefit. So it's important to put all them together. And we are talking about a meta-analysis of 36 trials. 20 trials on tocilizumab, 7 trials on sarilumab, so almost 20,000 people with COVID-19. Use of tocilizumab or sarilumab with corticosteroids was associated with lower mortality rate, but maybe less beneficial without corticosteroids. But at this point, after the first recovery trial, everybody had been, the standard of care, there was also corticosteroids. And you see that tocilizumab plus corticosteroid versus corticosteroid alone was 0.79, and sarilumab plus corticosteroid versus corticosteroids alone was 0.73.
So we go back to our patient case, the 45-year-old woman with the recent diagnosis of mediastinal lymphoma, admitted for febrile neutropenia mucositis. Remember that she was febrile. She was with a oxygen saturation of 89% resting on room air. She initiated vancomycin, cefepime, and micafungin. She was positive to COVID-19 testing antigen test. Should we start any treatment for this patient against COVID-19? I will start discussing this case. Obviously, I think we should start a treatment for COVID-19 because the severity of condition, because she is an immunocompromised and she is neutropenic, so there is a clear benefit in using antiviral, the first step for this kind of patient. I will personally starting using remdesivir because she is hospitalized, and this is the preferred drug for hospitalized patients. Remember that nirmatrelvir could be used also, but probably when the patient with IV, we would prefer to use remdesivir because the benefit is similar, but we have a lower rate of adverse event and a lower rate of drug-drug interaction when we use remdesivir compared to nirmatrelvir. I think we should also assess for bacterial superinfection. We have a patient, or even fungal superinfection, because we have a patient with a febrile neutropenia. So I will probably be careful to search for additional co-infection, superinfection. And I will assess the clinical outcomes to see if the patient may benefit for adding another antiviral or even in a second step, immunomodulating drugs. What do you think, Martin? Would you do the same or something slightly different?
No, I fully agree. Regarding antiviral and antibacterial, antifungal therapy, regarding anti-inflammatory therapy, I mean, Cristina nicely showed all the data of the trials, but I think we have to consider that these trials included also immunosuppressed patients, at least some of them. But of course, this was only a very minor share of patients in these trials, and I'm not aware of specific data showing that immunosuppression with tocilizumab or baricitinib or one of the other drugs that we discussed is in the same way beneficial in immunocompromised patients as it is in immunocompetent patients. And I think we have to, as we discussed for dexamethasone, have to be cautious with anti-inflammatory therapies in immunocompromised patients. Do you think it in the same way, Cristina?
Yeah, definitely, yes. Completely agree. It's not only, I think that, we say that IV remdesivir, but also there are maybe some drug interaction because she will be put also in antifungal therapy in other situations. So I think that nirmatrelvir, ritonavir will be difficult to be prescribed in this woman. But no, I totally agree with what you said. And we have to consider that all the data that we have seen were not specifically, as you said, conducting in severe immune compromise. So we don't have the evidence in these patients, a clear evidence of, for example, immunomodulators can work in these patients. So but for sure, if the clinical picture will deteriorate, I would use also immunomodulators.
What do you think the current guidelines can give us all important information for the management of this kind of patient, or they are more focused on normal standard patient? Because I think that this discussion was very broad and we include a lot of things that are not included in the current guidelines. So I think that what they did in Germany, that they with ESCMID, we are trying to do a consensus for a document for immunocompromised patients, because I think that current guidelines do not help us much in this specific setting. What do you think?
No, I
Yeah.
completely agree.
Yeah, I'm very much looking forward to the ESCMID guidelines on immunocompromised patients.
But also because, the guidelines relies on the evidence, and it's difficult to conduct a trial on this specific population, so it's difficult.
Yeah, I fully agree on that. We have to discuss some important take-home points. So I think that treatment of COVID-19 hospitalized patients depends on host, severity, availability of drugs, condition, program for the immunocompromised patient, and especially in terms of which kind of treatment, the chemotherapy, transplant, they have to follow for their underlying disease. I think that remdesivir is the most beneficial, especially in this group of patients, hospitalized patients and patients who are critically ill. There are still large debate, I think, in immunocompromised patients receiving immunomodulators. There are, experts that probably still consider immunomodulating drugs for the immunocompromised patient, but we also have to consider which kind of immunocompromised, because we know that we are talking about a very heterogeneous group of patients, going to mild patient with solid cancer receiving immunotherapy or chemotherapy, to patients who are transplanted or receiving high-dose chemotherapy, or patient with febrile neutropenia with leukemia. So I think that's a very broad group of patients that in some group probably immunomodulators are still useful, but in others probably immunomodulators are not useful anymore. And also probably antiviral treatment in these patients are very important. We should consider that to start at the very beginning antiviral treatment, and consider also dual antiviral treatment, especially in patients who would not improve early during the course of the first round of treatment. So I think we concluded with this webinar. It was a pleasure to be with you today and with my colleagues, Martin and Cristina. So thank you so much for your attention.
Thank you to our faculty for joining us, and many thanks to you, our listeners, for joining in. As a reminder to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcasts on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.